Uh, I'm sorry that there was a change in the topic that which you are reading here, mentioned here. I sent 2 abstracts. And the first one, which is mentioned here, I didn't get a response. And the second one, which I sent, I got a response, but that is missing from the program. So thank you for the organizers for accommodating that. Since morning, we are listening to the various tools which helps in diagnosing a disease, and then various treatment modalities for taking care of those diseases. But I'm going to discuss the patient's perspectives. That's in a busy clinic, we are always busy in diagnosing the patients and then managing them without finding time to listen to the patients. And I would like to tell you a story how it motivated me to go ahead with this work. In January 2013, a patient came to my clinic and he asked that he needs surgery for cataract. One eye was operated in a peripheral center and he could not get vision as per his expectations. So when I looked at the other eye, so the pupillary reflex was very dull. And I told the gentleman that I suspect that you may not be suffering from, after looking at the fundus and all that in the operated eye, that you might be a case of glaucoma, and let me investigate. And you can imagine the anxiety generated in that patient, and it took me almost 1 week to convince him that you are suffering from glaucoma. And he was not ready to accept that. So with that motivation, I started this work in March 2013 and completed in 14. That what the patient feels about a disease, that the quality of life in a patient of primary angle glaucoma in a tertiary eye care center. Now, all of us know it is a progressive disease which ultimately leads to optic neuropathies. Of course, there is a death of the ganglion cell axons, and there is a demonstrable visual field defects also. Now, quality of life is an individual perception that varies from culture to culture, and that is our own, belief and expectations, and these expectations, they differ from person to person. Now, that disease may affect our physical health, then the psychological state of mind, as I have told you, that the anxiety generated, and the level of independence in that particular person, and various social and environmental factors which affects that person. Now, in case of glaucoma, the anxiety generated by the diagnosis of that disease, as I've given an example, the visual function loss because of the disease, and third is the medicine which we are using. Of course, it costs something to the patient. A compliance again matters, and the side effects of the treatment which the patient is getting. So a prospective cross-sectional study, which was unmasked, was planned and conducted for almost a year with 50 patients, though the sample was small initially, and that study is still continuing. But I'm presenting the results of those 50 cases, age-matched and sex-matched. So exclusion criteria were those which are likely to create a bias, like cases of closed angles, or corneal opacities, or optic nerve disease, or cause other than the, neuropathies other than glaucomas. Patients of high myopia, any previous intraocular surgery, or any systemic disease or chronic ill health which is likely to disturb the psychological state of mind of the patient. All those were excluded. Now, these patients were categorized, or staging was done as per Nelson's criteria, that it's mild, where there was a unilateral loss with less than half of the field. Moderate cases were selected, that unilateral loss with more than half, or bilateral less than half. And in severe cases, these were bilateral cases more than half. Now, the question was, which questionnaire is to be adopted, whether it is NI-VFQ-25 or, GQL-15. Literature search told that both are equally good, but this is specific to the disease, GQL-15, and simple to administer. That's why we chosen this. A voluntary survey was conducted and a single trained interviewer conducted the interview. Now, this consists of 15 questions, that is sent for central and near vision, 2 items, for peripheral vision, 6, for dark adaptation glare, again 6 items, and 3 for this outdoor, 1 for outdoor modality. Now, the scoring is as defined there in GQL, that is 0 is abstinence from activity owing to non-visual, say, regions. Person having 1 score, no difficulty in the day-to-day life, and ultimately 5 with severe difficulty. These were categorized. Now, the comparison of these scores were done, and all these summary scores, they told us that this is higher, sorry. So those were having high figures were found in POAG as compared to the controls, and there was a negative proportion, that means worse quality of life scores if the scores are high. And glare and dark adaptations were affected the most. The mean scores in all the 4 domains was higher. Sorry, it is a repetition of the same slide. Now, if you look at the data, that if we compare this, that mean scores in cases and controls, in all these cases, these all the 4 subscales, we find a higher score in cases of the cases in comparison to the controls. So there was a gradual increase in all the domains was noticed, and deterioration was noticed as with the progression of the disease of the glaucoma. That is, in severe cases, it was the worst, and you can compare all these figures, that is mild, moderate, and severe. Now this figure is increasing, number is increasing, and all were statistically significant as per. Now these are the comparison of all these scores. That is, all the subscales, you can find that in cases there was a higher number or higher score in comparison to the control in all the 3 categories. Now, comparing the urban and rural, that was very important, depending upon their literacy status and their knowledge about the disease. So the mean scores do not show any difference in urban rural patients in any of the domains, but the scores of rural patients are worse in all domains except central and near vision, in which the urban patients reported more difficulty. But that can be attributed to the poor education and the illiteracy of the patients in rural areas. So if you look at these scores, we can compare easily that except this domain, all the figures were higher in cases of, say, except this central vision, all the were more in cases of almost equal, sorry. Summary score was equal. The illiterate patients were found to have worse quality of life scores in central and near vision, and the task related to glare as well as dark adaptation affected more in illiterate patients. Now you can compare all these scores in all the subscales. So, except in central vision, it was more in cases of the illiterates. Then male and female, statistically these were equal, but somehow the summary of the scores that was equal in both, but in cases of these were more affected in case of male patients as compared to the female patients regarding the outdoor mobility. So we can compare here. All the subscales, they were more in males, the scores were more in males in comparison to the females. Then correlation with the visual acuity. Of course, the visual acuity is a important factor, and decrease with the visual acuity, there was a poor quality of life. That is accepted fact. So if you see this correlation in the worst eye as well as in the better eye, all these were related to the poor quality of life. Now the mean down scores as well, GQL 15 scores in our study are higher in cases than the controls. So that was an accepted fact. And the difference in mean was statistically significant. The higher mean score in POG indicates poor quality of life in cases of glaucoma as compared to the normal controls. So these findings are consistent with the findings of Goldberg as well as Onkaya. And again, in a study, tasks involving glare and dark adaptations are most affected. Again, consistent with the findings of Onkaya as well as Naveen. So mean scores in mild, moderate, and severe glaucoma, they were naturally worst. And again, with the progression of the disease, these are comparable with the other studies in the literature. So the conclusion is that POG negatively affects the quality of life. And quality of life decreases with loss of visual functions, that is visual fields as well as the central visual acuity. And effect of POG and quality of life is variable. Tasks related to glare and dark adaptation are worst affected as per this study, and the major determinants are gender and the literacy. As I've told you, that somehow, depending upon the literacy as well as the gender, there was a slight difference. So these are the few references. Thank you very much.